Welcome to today's specialty testing webinar on improved diagnosis of necrotizing autoimmune myopathy by combinatorial immune assays. This is Brian Brose, Product Manager for Mayo Clinic Laboratories, and I'll be facilitating today's conference call. Our presenter today is Dr. Christopher Klein, Professor of Neurology here at Mayo Clinic in Rochester, Minnesota. Dr. Klein is boarded in muscle and nerve pathology and in neuromuscular medicine. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function. If you are participating in the audio-only portion of the program, we'll allow you the opportunity to unmute your lines at the end of the presentation. Today's program is being recorded and will be posted to our website in just a matter of weeks. And now I'll turn it over to our presenter, Dr. Chris Klein. Thank you.
Thanks, Brian. I'm very happy today to talk to you all about what is a very serious condition, which is necrotizing autoimmune myopathy. And these are our objectives. I hope to teach you about the condition and let you know about work that's going on both in the research arena but also in our clinical laboratories to improve the speed and accuracy of diagnosis among these very seriously affected patients. So I have really no relevant disclosures. I do want to emphasize, because this condition is quite rare, there have never been true randomized blinded controlled trials to allow for FDA approval of immune therapy specific drugs. So if you hear me talking about specific drugs, it's basically based on expert opinion and experience. So when we talk about autoimmune neurologic disorders, and specifically those as related to the peripheral nervous system, there are a number of these that have a specific antigenic target, and that antigenic target can originate in the nucleus of cells, or in fact, it can originate on the cell membrane of cells. And that's a very important point, and it'll be relevant for today's discussion. So disorders where the antigenic target is actually on the cell membrane, these are conditions that more commonly will have an immune responsive phenotype and may be less likely for many to not have a underlying cancer driving them. And so, when we think about the origins of these autoimmune neurologic syndromes, frequently a cancer is driving the process. So something in the cancer has sequence homology to something out in the peripheral nervous system that is sort of innocent bystander injury as we fight our cancer. Some are actually infectious etiologies. So we see an infection and attack it, and it has some homology to a neuronal sequence. But then for a large variety, we don't have a specific trigger. And today we're going to talk about the association of one drug, which are a class of drugs called statin medications, as a trigger for autoimmune myopathy. So, historically in the autoimmune myopathy arena, we have used pathology as the mainstay for diagnosing such patients. And so here are some different examples of autoimmune myopathy. Dermatomyositis is probably the most famous, and these patients have this characteristic perivesicular atrophy, paramecial inflammation, and varied T-cell response. Polymyositis has a characteristic T-cell response, but without frank necrosis of muscle fibers. Inclusion body myositis will frequently have these vacuolar changes and marked inflammation. And I show you Duchenne muscular dystrophy, although we recognize this as a genetic myopathy. What these kids actually have is a profound amount of inflammatory reaction to that degenerative process. And in fact, now many children with that genetic condition are placed on steroids, and has been shown to increase their not only ambulatory times, but also probably their survival. Today we're going to be talking about this particular pathology. This is called necrotizing autoimmune myopathy, and it has a very characteristic feature, which is of frequent necrotic fibers that are invaded by macrophages, but there's very little or no T-cell response out in the periphery. So there is a kind of characteristic muscle pathology for these patients. So this has historically been around, of course, for a long time, and the nomenclature has been quite varied throughout the ages, if you will. So I'm referring to it as NAM simply because I think that's easy to say, but others have referred to, and now the current classification schemes talk about it as immune-mediated necrotizing myopathy. So you'll hear that and see that in the literature. Others have called it immune myopathy with myocyte necrosis. And now in the modern era with the association of certain antibodies, you may actually hear it referred to as related to the specific antibody found. So anti-HMGCR myopathy or anti-SRP myopathy. And then there's a group of these that have the characteristic pathology and clinical history of NAM, but are negative without a specific antibody, and those are simply referred to as seronegative NAM. So I think a couple important points I want to start off with and reemphasize throughout the talk is that these patients are seriously ill, and increasingly we're recognizing this is a neurological emergency. And that's partly related to the fact that delay in diagnosis has been now established firmly to be associated with worse outcomes. So as you look at the pathology, you can kind of understand that when these muscle fibers actually die and become necrotic, your chances for meaningful recovery diminishes as more of that occurs. There are certain very pathognomonic features for this condition, and part of my mission today is to make you aware of those features and to eliminate some of the confusion in the diagnosis. So almost all these patients have markedly high CKs, almost always above 1,000, sometimes as high as 20,000. And so that marked elevation can itself lead to complications with renal tubular injury with significant rhabdomyolysis. And other patients may present in respiratory distress because of weakness of the diaphragm or protective muscles of breathing. And so another important feature which makes this a very significant disorder is the common association of these patients with cancer. So as much as 30% of patients will have an underlying malignancy either identified at the time of their first myopathy presentations or within a 5-year period of time from the diagnosis. And so
the recent discovery in 2010
and the earlier discovery of SRP54 has really revolutionized how we diagnose and think about the clinical classifications of these disorders. So there are certain risks that are important to recognize. For the patients who develop the statin exposure HMG-CR antibody, it's been recognized in about 70% of these patients they have an HLA-DRB11 :01 haplotype, and this in the normal population only occurs in about 10%. So there seems to be a predisposing immune marker for patients with this condition. This condition tends to be most commonly in adults. There are rare children that have been reported, but almost all the patients are adults. There's been association with both HIV and hepatitis C. There's been association with various connective tissue diseases. And now in modern era, through the advent of new autoimmune therapies for cancers, the PD-1 checkpoint inhibitor therapies are now being associated with this condition. So we really do not completely understand the pathogenesis of both the autoantibody-specific NAM patients. So in 2000, Andy Maneman and Christopher Stein recognized this antibody against HMG-CR. And before that, and in fact, just as early as 2000, if you looked into the review articles about the mechanism for statin-exposed myopathy, it was initially thought to be a toxic phenomena where the statin exposure led to either cholesterol metabolism issues on the membrane leading to leaky muscle cells and rhabdomyolysis. Others have theorized that the abnormal cholesterol metabolism led to reduction in coenzyme Q10 and therefore a underlying pathogenesis through both toxic mechanisms. However, now what we recognize with these specific IgG antibodies, that there probably is an aberrant association between the drug and the enzyme that leads to a loss of tolerance for HMG-CoA, the enzyme that's important in statin metabolism. And there's been some fairly elegant experiments done here in the last 2 years demonstrating that a good portion of the antibody response is actually on the muscle membrane. And that relates to my earlier comments about the chance for a therapeutic response. And there's been other data to suggest that the level of the autoantibody is associated with severity and treatment response. So SRP, signal recognition protein 54, is the antibody linked to NAM in such patients. So this group of proteins are extremely ubiquitously expressed. They're essentially in every cell that is making proteins. And so it's not entirely clear why a protein that helps dock translation production to the Golgi and endoplasmic reticulum has been specifically targeted. But also here, it's been demonstrated that this particular antigen is upregulated on the cell surface of muscle fibers and, in fact, is a target for disease. Here also, there's been association with the level of the antibody and the severity of the myopathy and the response to immunotherapy. But the main message I want to give you, despite the beautiful slide here, is that we really are fairly early on in understanding the pathogenesis of both these autoantibodies as related to necrotizing autoimmune myopathy. Okay, so let's put this disorder in perspective. So, and this perspective is rapidly changing with improved understanding through autoantibody discovery in the space of idiopathic inflammatory myopathies. So overall, this entire class is fairly uncommon in the population, with only 15 to 30 persons in a population of 1 million being affected. And by far, dermatomyositis patients are the major bulk of idiopathic inflammatory myopathies. They tend to be more commonly female, and the occurrence here is about 9 to 10 persons in 1 million. Inclusion body myositis is more common in older men, and in fact, 80% of these patients are males. And this occurs at about 8 per million persons. Now to the entity that we're discussing today, necrotizing autoimmune myopathy. So there does not appear to be much of a sex predilection, and the frequency of this condition is about 5 in 1 million persons. The important thing, though, distinguishing it from these two other disorders is that many of these patients will be first seen in the hospital setting, either because of rhabdomyolysis or from early respiratory involvements or early and rapid onsets of ambulatory loss. So increasingly, through the advent of autoantibody discoveries, and specifically the anti-synthetases, we now have coined a new phrase referred to as the overlapping myositis category. And by far, these are more commonly women, and the frequency here is approximately half of that of even necrotizing autoimmune myopathy. So these are extremely rare conditions. They can be associated with other non-myopathy complications, including interstitial lung disease and most commonly skin manifestations. So, but they're much more rarely going to be admitted to the hospital because generally their myopathies are less severe. Their hospitalizations more commonly relate to lung involvement. And so lastly, polymyositis. There's a huge debate in the myopathy community about the true frequency of this condition, but as increasingly we discover new antibodies and we're critical with the pathology, this condition, in fact, is quite rare. In fact, the most recent estimates suggest it's no more than 2 persons in 1 million, and again, more commonly female. So this is a summary of the non-specific or myositis-associated antibodies that are encroaching into the space of inflammatory myopathies in terms of diagnostic tools. And importantly, they are not specific for most of these conditions, but they are frequently associated with these conditions. and that includes this antibody here, CN1A. This was originally observed to be very common in patients with inclusion body myositis and was thought to be very specific, but increasingly we now recognize that patients with Sjogren's, lupus, and polymyositis can also have this antibody. So in general, these antibodies have less specific clinical associations. Rarely are they associated with severe myopathy, but frequently they're associated with systemic autoimmune conditions. So now to the specific myositis autoantibodies. I've mentioned two already, SRP54 and HMG-CR. And the important thing to recognize is that among the inflammatory myopathies, this group, NAM, has the highest frequency of autoantibody discovery. And as we're going to talk about later, the antibodies found have very specific implications for patients affected by these conditions. So, and I've listed here the other myositis-specific autoantibodies, most famously Jo-1, which is actually fairly common among patients with dermatomyositis, occurring in up to 24% of patients. And this can associate with other systemic features, including lung and most commonly skin manifestations. But then I'm just cursorily listing these here. These other specific autoantibodies, again, are fairly infrequently found, but occasionally have specific implications into the patient's outcome in the phenotypes of dermatomyositis among all of these. And I'd like to just highlight the TIP1 gamma autoantibody, as that particular antibody is strongly associated with cancer. So if you have a positive TIP1 in the setting of dermatomyositis, you have a 58% positive predictive rate of having an underlying malignancy, and if negative, a 95% negative predictive value. So in this particular scenario, although uncommon, this can be quite helpful in working up your patient. So this sort of summarizes, this is a nice review by Betteridge and McHugh, the autoantibody environment and the usefulness of these antibodies in helping predict underlying malignancy, associated skin changes, and associated lung findings. And today we're going to be focusing on this group, those that are associated with necrotizing autoimmune myopathy. So an important thing to remember among those specific and non-specific autoantibody markers is that most of these, when they're not NAM, have a skin manifestation. And so, for instance, in dermatomyositis, it's very common that patients have a heliotropic rash, shown here, Guthrun's sign, which is these papules that appear out by the cuticle, and or these redness features on the extensor surfaces of their hands. They can also have other features that may require to remove the patient's clothes to see, including this redness, which has sometimes been referred to as the V sign on the front, and on the back the Shaw sign. And this, over time, evolves to a darker thickening of the skin, which has been referred to as poikiloderma. So these are features all you would be commonly seeing in patients with dermatomyositis. In contrast, patients that have the anti-synthetase syndromes, they may have other very specific features. For instance, palmar ulcerations happen with patients with MDA5, calcinosis with NXP2, and mechanic's hands, which typically occur on the radial surface of the thumb, this very dry skin that can sometimes be thought of as just exposure to chemicals or just simple hard labor. Okay, so where are we at in terms of the classification of these disorders? Well, I think there's considerable debate in terms of what and how these disorders bin out. This is a very detailed evaluation looking at all clinical features, pathologic features to consider where do we really think patients should belong. And so when this demographic blinded statistical analysis was performed, what you see is that there are four major classes of inflammatory myopathy disorders that binned out. And what's also significant is that polymyositis did not bin out in this group of patients. But, you know, I think that's more important to try and solve what we're talking about, NAM And as this little boy says to his teacher, let's solve these first. We can worry about data mining later. And so I'd like to get into some cases with you and kind of illustrate what we're actually talking about. So this is the case I saw. This was a 49-year-old accountant who had had for about 10 months a very insidiously progressive, painless weakness, and he had some coexisting comorbidities. He had high blood pressure, he had high cholesterol, and he was on a statin medication, lovastatin. And on the left, you can see his clinical examination. So no, he didn't complain of any facial features, but he clearly had facial weakness. He could not whistle. He had weaknesses of his neck, and more prominently in the neck flexors. He had weaknesses of his shoulders, which fit his difficulty in lifting his arms above his head at night when he'd try and help his wife do the dishes, put the dishes away. But his major findings were in the lower extremity, where he had significant weaknesses by the time he got into us of his hip flexors, such that his knee would buckle going up and down the stairs. But also, very interestingly, he had ankle weaknesses, and his weaknesses were more in dorsiflexion. So he had difficulties in going up the stairs without catching his foot. So he had a CK that was markedly elevated at 2200. There was no family history, and other markers for immune inflammatory causes were negative. So despite having discontinued his statins about 6 months into this, he continued to worsen. And so because he had this pattern of weakness with bulbar involvement, distal weaknesses, and a very high CK with insidiously progressive course, it was thought that maybe he in fact had limb-girdle muscular dystrophy. There was no family history because he was adopted. And so among the limb-girdle muscular dystrophies, there's a small list that have very high CKs and can have these kind of distal involvements. So I'd like to share with you his EMG, which is further confusing. This is a needle examination of his thigh. And I'm just going to start here, and I'm going to be quiet so you can listen to it. So this is an example of what was found in his thigh without him trying to activate the muscle, just by listening. And then in his deltoid, again, without activation of the muscle, just listening. So what he has here on the first recording of the thigh, myotonic discharges. And on this recording, has lots of irritability that includes CRDs and fibrillation potentials. Now I'd like to show you when he activates his muscle how those motor units appear. So I know we have a diverse audience listening today, but for the neurologists, these motor units are very polyphasic. They're with reduced recruitment, and there are very few motor units found, and that associates with his significant weakness. So when you have reduced recruitment, we're often thinking about a primary neuropathic, not myopathic process. But in fact, in chronic myopathies that do occur in limb-girdle dystrophy, this might be a characteristic feature. But further confounding it were what we heard on the first two muscles, which are myotonic discharges. And of course, that we think about with myotonic dystrophy. And so in fact, the genes for myotonic dystrophy were checked and negative. And he went on quickly to a muscle biopsy, which showed the characteristic features of none of those disorders, the genetic entities I discussed, but in fact, classic for necrotizing autoimmune myopathy, by having prominent necrotic fibers without T-cell inflammation. And so you can see here, this is a PSA stain. This is actually macrophage engulfment of those necrotic fibers. And so this is read out as a active in severe myopathy with frequent necrotic fibers. So with this, he underwent immunologic testing, and he was found to have elevated HMG-CoA IgG by our ELISA assay with 100 units per ml. He was also simultaneously tested for SRP, the other antibody, as I mentioned earlier, associated with NAM, which was negative. And so the interpretation here says this result supports the clinical diagnosis of necrotizing autoimmune myopathy. A muscle biopsy should be considered if clinically indicated. And, of course, it's emphasized that this can be associated with statin exposure and or people who have not been exposed to statins, but also emphasizes that cancer can associate with these patients. So he underwent a malignancy workup to find nothing. So this case emphasizes a couple different things, and I think the most important thing to take away from this case is the varied presentations. So generally, when patients have neck weakness, we often think of forms of muscular dystrophy. And in these patients, they tend to have neck flexor greater than extensor weaknesses. Additionally, when patients have ankle weaknesses in the setting of myopathy, we think more commonly of forms of limb-girdle muscular dystrophy. And that's also important to recognize that patients with NAM, frequently up to 50%, will have ankle dorsiflexor weaknesses. So this should not throw you to the diagnosis. Additionally, and especially seen in patients who have been exposed to statins, that myotonic discharges can be seen. So this should not throw you off to the diagnosis as well. The other thing is that infrequently patients can have these insidious courses. Most patients, more than 90%, will have a much more subacute rapid onset. And so this has led to consideration of limb-girdle and or FSH dystrophy. And so this is just a nice paper I thought I'd share with you. It's actually out just this week in the Sister Journal of Neurology. And this is work from the NIH where they took 11 patients that were felt to have limb-girdle dystrophy but had a negative genetic evaluation and tested them for HMG-CR. And they found approximately half of these patients had elevations of this autoantibody. And in fact, the diagnosis was probably wrong, and all along they had necrotizing autoimmune myopathy associated with HMG-CR. So this second case is of a 37-year-old woman who had a much more rapid onset of weakness occurring over 2 months, and she was not on a statin. She did not have bulbar weakness. She did not have neck flexor weakness, but she had fairly profound weaknesses of the lower extremity, and she could no longer climb or ascend stairs. She had no family history, and she had also a markedly elevated CK of 2600, which was associated with some elevation in her liver enzymes. She was checked for various autoimmune conditions, including primary biliary cirrhosis with antimitochondrial antibodies not shown here, which was negative, and she had a comprehensive autoimmune cascade, which was unremarkable. Her EMG also showed a myopathy with fibrillations, and she underwent biopsy. So her biopsy was interesting in that she had far less frequent necrotic fibers, but she also had this collection of perivascular collection in the paramecium of inflammatory cells. So when we see paramecial inflammation, we commonly think about dermatomyositis. This lady did not have any skin changes, and she was initiated on treatment for an inflammatory myopathy per this report. And subsequently, she was later tested with our combinatorial assay to find that she also had HMG, in fact, at a much higher value than the first patient, over 200 units per ml, and she was negative for SRP. So this is how she did. She was initially placed on high-dose steroids. She actually had no improvements. She had marked fibrillation potentials. And so it wasn't until about 6 months in that she was treated with an additional medication in the way of Cellcept. And with that medication, at a year's time, she had significant clinical improvements, and you can see by her EMG that the extent of fibrillation potentials here were markedly improved. So the important points here are, one, you do not have to be on a statin to develop HMG-associated autoantibody myopathy. In fact, depending on what paper you read, the number of patients not having received a statin can be as high as 50%. That EMG is helpful in following treatment response, as evidenced by reduced irritability in the muscle with reduced fibrillations and reduced myotonia if that is present. But also an important key to this patient's course is that the inflammatory infiltrates can be seen in about 20% of NAM patients. And so she did not have an occult dermatomyositis. In fact, she had NAM all along. So the other thing to keep in mind, that this being such a severe myopathy, large data sets now have demonstrated that over 90% of patients will need more than just one immunotherapy at the onset of their disease to try and get stabilization or improvement. And this is the nice series of 6 patients studied in detail from Sydney, where frequently you can see they had steroids, and without the addition of other immune suppressant therapies, including azathioprine, rituximab, methotrexate, IVIG, they tended to worsen. So for patients with this condition, an early diagnosis with an autoantibody, a muscle biopsy, can lead to the immediate initiation of combinatorial immunotherapies. Okay, and I'm going to do one more case, and then we'll move on to some discussion. This was a 41-year-old woman I saw who had a much more rapid course even than the second case I described, with a distant history 3 years early of colon cancer with local metastases, status post-resection, who had other comorbidities of alcoholism and Raynaud's phenomena. And she was actually admitted to the hospital not only because she was weak, but she had difficulties in swallowing and shortness of breath. Her CK was significantly higher than the first 2 cases, with a CK of 12,000. So her urine was actually dark, and she had swelling of her extremities. On additional autoantibody testing, she had a slight elevation of GAD65. That antibody is linked with predisposition to diabetes or autoimmune thyroid disease, and she had a positive ANA with a family history of rheumatoid arthritis. So initially it was thought that she may have a paraneoplastic-associated myopathy. She underwent PET and a colonoscopy not to find an underlying cancer. So her EMG was similar to the first 2. She had multiple fibrillation potentials, and her biopsy was also similar by having necrotic fibers that were not associated with any significant alternative inflammatory infiltrates. So the thing that I've not talked about yet is this. This is the tissue-based immunofluorescence pattern that we have seen in patients with NAM. And in fact, this was her pattern. So what she has here is on the mouse substrate, selective staining of the proximal mucosa with sparing of the distal mucosa, positivity of the myenteric plexus, positive staining of the Purkinje cells in a cytoplasmic pattern, slight dentate staining, and choroid plexus staining. So this pattern was recognized by Dr. Van de Linnen in association with patients with necrotizing autoimmune myopathy. And so this same pattern has been recognized with SRP54, the specific antigenic target that has been most strongly associated with NAM. But in her case, by immunoblot assay, she was negative for the SRP54 antigen staining. So this summarizes her report, where she has a negative HMG, a negative immunoblot, but a markedly positive and titrated SRP-IF pattern. So in this particular case, the report reads a little differently, in that SRP antibodies detected by IFA in the context of a negative immunoblot have been observed in autoimmune conditions, and therefore this result needs to be interpreted with caution. So the other autoimmune conditions can include polymyositis, forms of mixed connective tissue disease, but increasingly what we're learning is that patients can also have mixed connective tissue disease with NAM. So a number of lessons can be taken from this third case. First of all, that this is a very serious condition. 30% of patients have respiratory involvement, including with respiratory deaths. And in nice review articles looking at death from SRP, as many as a third of patients may die from this particular entity without early treatment. These SRP patients with NAM tend to have younger onsets, have more commonly bulbar involvements, and frequently need more aggressive immunotherapy. And increasingly, we believe rituximab up front may be the choice of the medication of choice for these patients. So next, we now recognize that SRP54 immunoblot patients all have the SRP-IF pattern in our hands, and that not all SRP-IF positive NAM patients have SRP54. So I'd like to take you now to the data that we had obtained through our validation process for the assay that I've been demonstrating throughout the talk. So this is our cohort. So these are all patients who had been examined at Mayo Clinic, who had undergone muscle biopsy and had specific diagnoses based on the combination of the muscle biopsy, the clinical features. And so we have 43 patients who met the criteria for NAM that were tested, and 35 non-NAM patients that were tested, and this all relates to the SRP evaluation. And so what we learned is that all those patients who had a positive SRP54 by the immunoblot also had an IF positivity. But not all patients with SRP-IF had a positive immunoblot. So, but we also learned about the specificity of the SRP-IF. So, in fact, we had 2 patients that were not felt to have NAM that had positive SRP-IF. And so when we looked back at those cases carefully, they actually had treatment course, meaning multiple immunotherapies were required in order to get them into cessation of the disease. And both cases had been associated with a mixed connective tissue pattern. The one patient associated with graft versus host disease with liver transplant associated with autoimmune hepatitis, and the second patient who had multiple connective tissue markers. So I think what we're learning from this experience and experience in the literature is that NAM patients, although they sort of exist in an entity alone, they can have overlap, most commonly with mixed connective tissue diseases. So, and those patients frequently have SRP positivity. There is a rare patient that also has one of the anti-synthetase antibodies, but in general, these patients either have HMG, SRP, or no autoantibody of any type discovered. So this is echoed in the work from Allenbach from France. So this is their large cohort of NAM-positive patients. And what they also learned from that experience is that many of these patients have extramuscular manifestations, including features of rash. They did not mention Raynaud's, as was the case in our patient, but also interstitial lung disease. So there's sort of a crossover, if you will, in these NAM patients with positive SRP. But regardless, they also needed very aggressive therapy, very characteristic of other NAM patients. So just historically, I wanted to review with you, because the strength of the SRP evaluation, the historical approaches to identify SRP. So initially, transfected HEP tube cells were utilized to look for SRP, but it was recognized that there was a difficulty in specificity with that expression. The other attempts using immunoblots with non-radionucleotide staining, and what we see is it's sometimes difficult to visualize that very light band. In contrast with a radionucleotide precipitation, you can commonly see the band better. And there's actually been an attempt to use radioimmunoprecipitation assays, and those are being used by many of the commercial laboratories currently. But then the immunoblot assay, which has the ease of a single band at high resolution. And so what we think we have here is basically a better mousetrap, in that we recognize more patients with SRP, both with SRP54 confirmed on our immunoblot, by utilization of this IF assay. And in fact, we recognize that we're able to increase our sensitivity for a NAM immune diagnosis by utilization of this tissue-based assay. And so again, I wanted to call out Dr. Lennon and Dr. Maloney and Dr. Kasarjian for making this initial observation here at Mayo. And this paper summarizes their large clinical experience with not only the antibodies, but also the clinical presentations. So the HMGCR assay is much more homed. It's a single assay through an ELISA method. It's been very well vetted to have a very good cutoff rate, and it's highly specific, near 100% specificity. And that was true. I'm not showing you our validation data here at Mayo, but when that same cohort was run for those that were SRP or SRP negative, we had a very high hit rate with that. And so this is the Mayo approach. So we parallel process the HMG ELISA assay with an immunofluorescence assay. And so any patients that have the fluorescent pattern are then reflexed to the immunoblot. And by doing that, we only gained in sensitivity without significant loss of specificity. So right now with that combinatorial approach, we not only give an endpoint titration for the HMG, we can give an endpoint for those patients who are SRP54 positive by ELISA, but of those that are SRP positive with a negative IF. And so overall, this results in a clinical sensitivity that's remarkably high at 71% and a specificity at 95%. The other thing that's great about this very focused assay is the turnaround time. So we're able, by parallel processing this, to have most turnaround times in the sort of 3 to 5 day range, with most all patients being completed by a week. So I think that emphasizes why we're favoring this assay, the sensitivity, specificity, the quick turnaround time, and also the importance of the clinical report. So we recognize that the HMG-CR is the most specific finding and has not been linked to other forms of autoimmune myopathies. So in patients with an HMG-CR positivity, it may not be necessary to advance to a muscle biopsy. But patients who are negative for that antibody may benefit from biopsy looking for mixed connective tissue disease or other confounders to an autoimmune myopathy. So lastly, I'd like just to say that depending on the specific findings, we know that patients with SRP would be more commonly to have lung involvement, that they probably need more aggressive therapy with even rituximab at the onset, and that gives us some additional prognosis by utilizing this combinatorial approach. So before we do the questions and discussion, I did want to acknowledge not only Dr. Lennon's research discoveries, but also our small cohort within the neuroimmunology lab that has been focused on autoimmune peripheral nervous system diseases, and that includes Dr. John Mills, who's one of our co-directors of the neuroimmunology lab, Dr. Devanshu Dubey, who is new to staff, and Mr. Matt Roforth, who is an amazing technician helping us move these tests out to clinical application. And this is, of course, our entire group, with Dr. Lennon shown here in front. And then our laboratory support persons. So if you have a patient in the hospital with NAM and you're wanting to talk to one of us, you can simply reach us through client calls, and or you can talk to us or one of the fellows about the results of your patient. And then this is that group I mentioned, our illustrious group. And I forgot to mention Dr. Shahar, who is a fellow working on the lab helping us with these endeavors. So now we'll move to the questions.
Fantastic. Well, thank you so much, Dr. Klein, for the deep dive into this important topic. As Dr. Klein mentioned, at this time, we would like to take any questions that any of you may have. We will follow any chats any questions that have been submitted through the chat. So if you have questions, please submit there. Also, if you would like to ask a question verbally, you may press *7 to unmute your phone, and we can take your question that way as well. So feel free at any point to do that, press *7, but in the meantime, I will ask some of the questions that have come through the chat so far. So Dr. Klein, it looks like we have one regarding prevalence of myopathy in relation to Hashimoto's and lupus. Can you respond to what you know there?
So, sometimes there's associative conditions, and that sort of falls into that group of antibodies that are not specifically causal, but they're associated. So both Hashimoto's and lupus are linked to a group of patients who have either mixed connective tissue disease or lupus-specific myopathies. So I think that their pattern on muscle biopsy may be quite different. In those conditions, a muscle biopsy can be extremely helpful in guiding any therapeutic approaches that might be tried. But in general, the associations with myopathy in those groups are much less common.
Great, thank you. So there's another question here with regard to the association of NAM and statin use. So knowing that muscle weakness is a side effect or can be a side effect of any patient on a statin, but not necessarily be NAM, what sorts of guidance would you have when determining when proceeding to autoantibody testing that's being described here is warranted versus from other forms of muscle weakness that they may be experiencing?
Both these questions are very good. That's a superior question in that if you think about the entire population and how many people are on statins, commonly myalgia, as many as 5% of patients on a statin will have a myalgia complaint. But only a very small percentage of those people have this condition. In fact, it's thought that probably less than 2% will ever develop this serious complication. And so what is extremely helpful is discovery of any weakness, or very useful is a markedly elevated CK. So the benign myalgia of statin exposure is not going to be associated with an elevated CK. So, laying hands on the patient, making sure they're not weak. And for thighs, it can be very difficult. A strong thigh by direct manual muscle testing may be hard to overcome. So generally we're having patients kneel, get up off the ground, tell us how they do on stairs. That can be a better indicator. So, but I would just emphasize the importance of checking a CK, and if it's over 1,000, you're probably going to be dealing with something that's, what may be a medical emergency depending on the rate at which they're progressing. So in fact, I want to share with you that when this antibody was first discovered, Andy Mammon's group from Hopkins and the NIH looked at over 1,000 patients who had myalgia, and they could not find this antibody in that group of patients. So it's a very specific antibody, and in that cohort, if there's uncertainty, commonly I see very muscular males that have CKs hovering right around 700 to 1,000. Is that normal or abnormal for somebody really muscular? Can be hard. So in that case, I can't overcome them on the bedside. It might be efficient just to check the HMG-CR, because if it's positive, you're dealing with a very specific thing.
Great. That's very helpful. It also ensures proper utilization so that not every patient with muscle weakness is getting this sort of testing. So that's a great distinguishing factor there. So the last question that I see here on the chat is with regard to this focused antibody testing for NAM and then broader myositis testing. So you talked about some of those markers earlier on in the presentation. When is a broader approach to myositis testing ever warranted, or are these patients, very well phenotyped where to pursue a very focused NAM evaluation versus broader myositis testing?
I think that's a very difficult question and a very good one. I think we're all wrestling with that right now. So I want to just emphasize that the majority of your patients with dermatomyositis are going to have skin manifestations. And the majority of those patients are not going to have CKs in the levels that we're seeing, with NAM. So again, the CK is a very useful, point in the road that you might vary from. So should you not also check for antisynthetase and other antibodies? I think it's going to be personal preference. Doctors never want to miss anything, so we frequently overdo it. But I think that the take-home points from me with NAM are that it's a very serious, rapidly progressive disorder. I don't want to wait for a very comprehensive but less useful assay that may not change my management. Whereas NAM evaluation will really change your management, and it'll change it in a rapid way. So anymore, if I have a positive evaluation, or if friends of mine who are taking care of these patients much more frequently than I do get a positive evaluation for the NAM, they're doing combinatorial treatment up front. And this is something you would probably never do in dermatomyositis or some of the other conditions where those antibody discoveries are much less frequent. So remember, if you look at our cohort of NAM patients, 70% are going to have a positive antibody test. In contrast, for dermatomyositis, for any individual patient, that hit rate is going to be at most 20%. So, and then with rare exception, those antibodies will probably not change your management. Whereas the NAM antibody, whether it's SRP, which you're going to probably even be more aggressive with, definitely changes what I'm going to do. And I know right away, I know within a week what the result's going to be. So I hope that's clear, but I do want to emphasize we're still working this out. And in fact, one of the things we're involved with in the laboratory is really critically looking at all our send-outs and the positive predictive value for these tests, and do they change management? Because we're trying to get patients to the right test, and that's one of the major reasons we focused on this one first, is we knew this is a very important autoimmune syndrome that we don't want to miss, and we want to provide the best assay. So that's why we focused all of our energy on this up front.
Well, I want to thank you again, Dr. Klein. And for everybody on the call, thank you for participating in today's specialty testing webinar, and have a good rest of your day. Thank you so much.